Good morning, everyone. We'll be talking about antiarithmetics today. Before we move ahead to the presentation proper, let us have a brief overview. The heart has specialized cells that generate rhythmic action in the absence of external stimuli. These pacemaker cells depolarize slowly and spontaneously due to an inward positive current carried by sodium and calcium ions. An irregular cardiac rhythm can be caused by a malfunction in impulse production or conduction at any of the many places in the heart. Arrhythmias are a diverse collection of illnesses with a wide range of symptoms. To make sense of this wide set of illnesses, arrhythmias are categorized according to the anatomic location of the abnormality: the atria, the AV node, or the ventricles. The diagram on your right illustrates several medication classes used to treat cardiac arrhythmias. Most arrhythmias arise either from aberrations in impulse generation or from a defect in impulse conduction. The first cause of arrhythmia is abnormal automaticity. Because the SA node discharges at a greater rate than other pacemaker cells, it generally sets the pace of contraction for the heart. If cardiac locations other than the SA node exhibit heightened automaticity, conflicting impulses may be generated and arrhythmias may occur. The majority of antiarrhythmic drugs work by inhibiting sodium and calcium channels. The second cause of arrhythmia is abnormalities in impulse conduction. A phenomenon called re-entry can occur if a unidirectional block caused by myocardial injury or a prolonged refractory period results in an abnormal conduction pathway. It is the most common cause of arrhythmias, and it can occur at any level of the cardiac conduction system. Antiarrhythmic agents prevent re-entry by slowing conduction and or increasing the refractory period. Antiarrhythmic medications are categorized based on their major impact and the action potential. Although this categorization is useful, it does have certain limits. Many antiarrhythmic medicines have activities that are related to more than one class, have active metabolites that are related to a distinct class of action, or have an action that does not fit to any of the formal categorization. With the class 1 antiarrhythmic drugs, this class act by blocking voltage-sensitive sodium channels. They bind more rapidly to open or inactivated sodium channels than to channels that are fully repolarized. The use of sodium channel blockers has declined due to their proarrhythmic effects, particularly in patients with reduced left ventricular function and atherosclerotic heart disease. Class 1 drugs block cells that are discharging at an abnormally high frequency without interfering with the normal beating of the heart. These drugs show a greater degree of the blockade in tissues that are frequently depolarizing. First, we have the disopyramide, which is a class 1A antiarrhythmic drug that is used to treat irregular heartbeats. It works by strengthening your heart's resistance to aberrant activity. Disopyramide is available as a capsule and an extended release capsule for oral use. For its mechanism of action, disopyramide produces a greater negative inotropic effect, and unlike the other drugs, it causes peripheral vasoconstriction. For its therapeutic uses, disopyramide can be used as an alternative treatment for ventricular arrhythmias and may also be used for rhythm control in atrial fibrillation or flutter. For its pharmacokinetics, disopyramide is well absorbed after oral administration and is metabolized by the liver by CYP3A4 to a less active metabolite and several inactive metabolites. About half of the drug is excreted and changed by the kidneys. For its adverse effects, disopyramide has the most anticholinergic adverse effects of the class 1A drugs. For example, dry mouth, urinary retention, blurred vision, and constipation. Disopyramide should be used with caution with potent inhibitors of CYP3A4.
So next for the class 1A antiarrhythmic drugs is quinidine. Quinidine is the prototype class 1A drug which binds to open and inactivated sodium channels, therefore slowing the rapid upstroke of action potential. It also has anticholinergic properties which may enhance AV conduction in patients with rapid atrial depolarization. Quinidine is used in treating atrial and ventricular arrhythmias, but according to Kapsong, it is rarely used because of its cardiac and extracardiac adverse effects, which I will be talking about in the next slide. As well as there has been availability na of antiarrhythmic drugs that are better tolerated. So quinidine is readily absorbed from the gastrointestinal tract and is eliminated by hepatic metabolism. The significant adverse effect of quinidine is the induction of synchronism in large doses or is observed at toxic drug concentrations. Symptoms of synchronism include blurred vision, tinnitus, headache, and dizziness. Other than that, it can also increase the risk of developing torsades point, which is a life-threatening ventricular tachycardia. Procainamide also slows the upstroke of action potential. It is somewhat less effective compared to quinidine when it comes to suppressing abnormal ectopic pacemaker activity and more effective in blocking sodium channels in depolarized cells. Procainamide is used in treating acute atrial and ventricular arrhythmias, and it's the drug of second or third choice after lidocaine or amiodarone for treating sustained ventricular arrhythmias associated with acute myocardial infarction. So for its pharmacokinetics, procainamide can be administered safely by intravenous and intramuscular routes and is eliminated by hepatic metabolism to its metabolite N-acetylprocainamide or NAPA and by renal elimination. In addition, its half-life is 3 to 4 hours, which requires frequent dosing. Take note of this: although procainamide is effective against most atrial and ventricular arrhythmias, many clinicians attempt to avoid long-term therapy because, aside from the requirement of frequent dosing, the significant or troublesome adverse effect of long-term procainamide therapy is a syndrome resembling lupus erythematosus, which is the most common type of lupus.